I know we had more than one lecture before me. They discussed insulin, so I tried to take off some slides and so to make it very quick. You got the slide changer? You don't have it? Yes, you can bring it, please, so we can start. Anyway, so I'm going to start to bring the slide changer. So this is just a bit of history of diabetes. This is the word first diabetes, word used, diabetes meaning to go through, and mellitus means honey. So it's honey going through the urine, and that's been known for many, many years, thousands of years. Diabetes is a very old disease. And we know that diabetes doesn't start with a certain point with the pathophysiology. It's actually a progressive disease. And as I told you yesterday, that the pathophysiology of diabetes is changing with time. And if you can see here that insulin, that's in the red line here, insulin goes up with time, and that's also insulin resistance. And because of the failure of the body to continue to produce insulin, actually patients develop insulin deficiency, and that's where insulin is needed. So it goes through years of changes, and the UKBDS, which is the biggest type 2 diabetes trial, told us that at the time of diagnosis, 50% of your beta cells are actually dead. So we know this is a fact based on real evidence. So we tell our patient that the moment your blood sugar is 7, that means your chances of needing insulin is going to be very high. That's why we talked about the pre-diabetes and making our patient not to reach this level of blood sugar of 7. Okay? This is a very interesting study looking at patients on the left side who have, with time, years of follow-up, the same insulin resistance state. But look what happened to their beta cells. Beta cells is dying with time. So it's not only insulin resistance cause beta cells to die, as we think for many years. Beta cells die by themselves, and we still don't know why, and we still don't have any drug that actually stops this death, the programmed death or apoptosis of the beta cells. And I showed you this yesterday, and we know that patient eventually will fail in compensating for his insulin release and develop diabetes with time, and here where insulin is required. This is to show you how insulin is produced in the body. So insulin produced in the body, not in the way we think, it's just a release of insulin. It goes through 3 different stages. One of them is oscillation. So insulin doesn't go flat in the body throughout the day. It actually goes up and down, up and down. My slide changer, please. My slide changer. Hello, on the back. So I can not go back and forth. So the oscillations happens throughout the day. And when you have the first meal, you get the first insulin response. And then a second insulin response happens, and then you go back to normal. ليش عندنا first to second؟ لأن our meals are not all carbohydrates. So you have to have a different mechanism of insulin to actually cover your meal. Now, with the oscillations, the question, why do we have oscillations? And nobody knows yet why these oscillations is, but probably because sometimes you need a little bit higher insulin to cover the baseline, and sometimes you need less. And there's lots of talk about it in the medical literature, but nobody knows exactly what's happening. Now, with diabetes, first you lose your oscillations. And these where the patients have some abnormalities in their blood sugar. هذول المرضى اللي ما عندهم سكر. And we see them sometimes يجي لك weird presentation. والله شكري شوي صاعد بعدين رد طبيعي. You do HbA1c, everything normal. Okay? And that's the first stage of abnormality that happens. Okay, it's working. Yes. Okay? That happens. And you can see here, this is the oscillations. And then later, you lose your first insulin response. And this is where your patients actually have this peak of glucose after meal. And then it corrects and it was normal. All this, these patients don't have diabetes. And they present very early. And later, you get the flat response to insulin. And this is where actually you develop diabetes. And this is where the patients start to have abnormalities. We know that this is the first and second response, you can see. And you can see the difference between people with diabetes in the orange and people without diabetes in the blue. And you can see the first phase is gone, and the response with the second phase is also delayed. And that's why patients have some abnormalities early in the disease. This is how it looked like. Every meal you have a peak of insulin. So based on your sugar, you're down there, the peak of insulin goes with your sugar. So what is wrong with the beta cell in type 2 diabetes? We said the first phase insulin response is gone, second phase then changes in oscillation and reversible low response of glucose-induced insulin release due to glucose or lipotoxicity, and increase in pro-insulin release because the pancreas keep producing lots of insulin, and so with the time you need to do with the insulin resistance, you get some of the pro-insulin is produced in type 2 diabetes. Okay. This is again another very old saying about diabetes, the melting down of flesh and limbs into the urine. How يعني شو معبرة الكلمة, people die through their urine, and people used to die of diabetes and nobody can do anything about them. We know that insulin in the diabetes, we're not going to talk about the others, actually covers two things. It covers the increased hepatic glucose production because it suppresses gluconeogenesis when you take it, and also it helps in the peripheral uptake of glucose in the system. So insulin works to the pathophysiology of diabetes. That's why we need insulin. In most of our cases, insulin is there in our system to use it to our patient. Many times, the patient don't like insulin. Some doctors don't like insulin because it's an injectable thing. But insulin basically answers some of the pathophysiology. This is 3 of the biggest trials using intensive therapy. You can see UKBDS. You can see the intensive therapy, basically using insulin and sulfonylurea. Again, in the DCCT, using insulin in type 1, and the Kumamoto trial, which is similar to the DCCT, but in type 2 in the Japanese. And you can see there's perfect line in reduction of HbA1c by using insulin in that trial at that time. So this is what we do for many, many years. This is how we think. You give oral, second oral, third oral, and then add insulin. And this is basically what we do in our daily life. And then this was abandoned for many years, and then we come back to it, and then basically you give the patient a chance away from injection. And that's a reasonable approach. So when to start insulin? You have to remember these 2 points. 50% of the newly diagnosed patients already have diabetes-related organ damage by the time of diagnosis. وايد أوقات احنا نشوف المرضى not coming for diabetes, they're coming with cellulitis, ischemic heart disease, first MI, and then you diagnose diabetes. So diabetes, as you know, it's a late thing. Achievement of glycemic control is urgently required to lower the risk of organ damage, and this happens in patients with acute coronary syndrome. We have lots of studies. فلما يجي المريض أنا عنده acute coronary syndrome and he goes out, I don't leave him on oral hypoglycemic agent. and there is evidence, the GAMI trial and the others, to show that actually giving insulin help the patient to reduce the risk of developing the next attack of heart disease. فالإنسولين have a role in the acute phase and also have a role in patient who is actually developing complications. This is oral monotherapy failure with time, and it's basically inevitable, and most of you have experience. يجيك المريض سنة سنتين 5 سنين then you have to use insulin, otherwise he's not controlled. And you can see at 3 times, 6 years and 9 years, by 9 years, more than 75% of the UK BDS required insulin because of the failure of oral agents. And also, failure of oral agents correlates with the beta cell function at diagnosis. And this is also calculated through, not through a clamp or something. This is just like a HOMA calculation. And you can see if your beta cells are actually not doing well, this is oral hypoglycemic failure. If you have more working beta cells, your oral hypoglycemic will work better. And this makes sense. That's why when our patient come with glucose toxicity, blood sugar of 15 and 14, first time he's not taking any drug, giving him oral hypoglycemic agent without insulin doesn't work, because we know that this patient will not get controlled very quickly. فاحنا نعطيهم insulin for a short while and then we withdraw the insulin. كم واحد منكم سوي كذي؟ Okay. You have to do more of giving insulin for a short period of time. These patients, and there is lots of proof that actually the beta cells work better. أنا أقول حق المريض إذا ما اقتنع أقول له مثل كمبيوتر ليهنك شو تسوي؟ طفه وشغله. So we have to help your pancreas by giving you insulin, and I give you 3 months and then we'll withdraw it again. And most of the patient will agree. And you know that diabetes control is not very well overall, despite all the medications we have. So most of the time, we do need to use insulin. This is attaining glycemic goals for type 2 using monotherapy. As we said, 9 years, you cannot get a good control unless you use more insulin. So insulin is one of our tools to make our patients well. So why insulin? So why we use insulin? Anybody? Beta cell is failing, so patient's presenting probably late in his life. Acute condition, somebody with very high blood glucose. Somebody with ketoacidosis. Somebody with ketosis. Somebody who is type 2 but he presents with weight loss or he's thin, probably insulin will be helpful. There are many reasons, okay? This is just to show you, this is one of the first insulin ampoules produced in the 20s. Insulin is a wonderful drug. It saved millions of people, okay? And this is 1922, Eli Lilly, when they signed the agreement, and this is their production site. And you can see there up the fermentation and stuff that they have, a very old stuff, okay? So, insulin therapy is superior to the treatment of patients with type 2 diabetes with acute myocardial infarction, and this is a fact. So, if you have somebody with acute myocardial infarction, you have to use insulin, as our colleague said. Patient, type 2 diabetes with a direct angioplasty for acute myocardial infarction, and critically ill patient. This is all proven by several trials, and this is just a summary of the approved. So anybody with acute cardiovascular event, insulin is the best drug to use for this patient. You may stop it later in the first 3, 6 months, 1 year, but always put your patient better on insulin. Current indications for insulin treatment: initial stabilization of patients with severe hypoglycemia, established patient with hypoglycemia crisis, gestational diabetes, although we still use now metformin, for example, in the gestational diabetes, and sulfonylurea, although sulfonylurea is not very much popular, but you can use it. Perioperatively, and patient in whom oral glucose lowering therapy has failed as you do in most of your daily work. Barriers, hypoglycemia. Hypoglycemia is one of the barriers to use insulin, but nowadays with the availability of analogs, hypoglycemia is much less. So we encourage you to use more analogs than human insulin. And I know analogs is not available in the primary care all the time, but probably now most of the primary cares have analog, do they? Mostly. يعني we tried, أنا شخصيا and some of our colleagues, we tried to stop bringing human insulin at all. يعني, we give Humalog to everybody, Kuwaiti or non-Kuwaiti, but it's not, we did not succeed yet. Okay, complex treatment regimen and patient education. There are many, sometimes, patients taking too many drugs. On top of his antihypertensive, lipids, heart failure, then he's taking glucophage 2 times, Dimacron 2 tablets, Januvia, Galvas 2 tablets. It's becoming too many tablets. And sometimes reducing all these tablets, for example, metformin and insulin, make the patient's life easy. And I do this a lot. And one of my colleagues was just asking me, patient taking huge amounts of insulin and metformin, and she's on DPP-4. Why should I give DPP-4? Because I'm giving too much insulin and she's not controlled. So, you know, you have to think about which patient to use. There are lots of patients that can be used. You can use DPP-4 with injection issues. The human insulin needs, you know, preparation, look at, الفيجن لازم يكون good. Most of the insulin pens is better and easier. طبعا, rarely you see a patient who actually doesn't like the pen. I have maybe 1 or 2 who actually won't. I have one young type 1 who don't want to use the pen. He used the vials. So it's, you know, patient's preference is there, but most of the patient will prefer the pen because the pen is easy to what can be carried out, and then nowadays the pen is very easy to use. Fear of weight gain, and we know that weight gain with insulin on average in the UK BDS is around 4 to 6 kilograms. فيجيني صاعد له 15 كيلو واقول له this is not from your insulin. Most it's from the food. And this weight reduction is reduced when you use metformin. So metformin, or if you have the opportunity to use GLP-1 with insulin, probably that will halt the increase in the weight. But the increase in weight is not as people think, like too much weight increase as the people think. Okay? This is the MPH, and the MPH was there since 1940s. This is just a bit of history, interesting history. And the lente, we don't have the lente. Anybody use the lente? Maybe somebody with a gray hair. Okay. Lente is not available in Kuwait. I used it when I was in Canada. It was available. It's a long-acting drug, but it's not a very good formulation anyway. So this is how the insulin is produced, basal insulin and prandial insulin. This is basically how the pancreas works, as you know. We have many drugs available. You can see the short-acting, the ones on the top, Novolog, Abidra, Humalog, mostly around 3 hours. Regular insulin, 6 to 8 hours. NPH, 12 to 18. Detamir, 12 to 24. And Glargine, 12 to 18 to 24. Tamam? So these are the ones available. Now we have the new insulin formulation, insulin degludec, which is going to be available also. And it also can last up to 48 hours, but it's not approved for 48 hours, approved only for 24 hours. And the FDA did not give them the approval. So there is ما في انسولين اسبوعي مثل ما الناس بالواتساب قاعد يدززونه وبالهذا. There is no once weekly insulin at all. Okay? And sometimes we use these long-acting, even Lantus or Levemir, we use it twice a day. And I use it often. For somebody with big doses of Lantus, I use it twice a day, although the companies sometimes don't like to say that, but we do use it, and there are lots of people around the world use it, and sometimes it works better for some patients. Okay. So commonly used insulin regimens, basal bolus insulin, and this is the most famous in North America. They like the basal bolus, although the basal bolus requires 4 injections a day and also requires a person who actually do some carbohydrate counting. So most of 90% من مرضى type 2 they don't do carbohydrate counting. Probably 10% the youngish type 2, we send them, they go. Most of them, they will go, they don't want to go through the carbohydrate counting. Carbohydrate counting is not easy. It needs a lot of thinking, although the thing is simple, but you need to test and see how much you eat, and probably a 50 or 60-year-old who have lots of things on his mind, you know, children and stuff, he just want to come and eat and go. So you have to think about it. Premixed insulin regimens, 2 or more premixed insulin injection. There is somebody asked me about using premixed insulin 3 times. I do use my premixed insulin 3 times. So on 30-70 or 50-50, okay? Although pharmacy sometimes do come back. Dr. Walid, ليش كاتب premix 3 times? I do. I use them all the time 3 times, okay? And so continuous subcutaneous insulin injection infusion, which is the insulin pumps, and mostly with type 2s as younger who actually have, you know, progressive disease. Usually we give them sometimes insulin pump, and they work very well actually with the glucophage. So these are basically the 3 ones we use. This is the ADA, and you can see insulin is put in the ADA on top of your option. So you can use it anytime. 2nd line, 3rd line, insulin is free for you to use based on your discretion and your assessment of your patient. So this is from the ADA. These are slides from the ADA. So you can see human insulin and analogs. And we always prefer analogs toward human insulin, okay? This is, if you put ADA, EAD statement, you can find it on the internet. It's free, you can download it, okay? And this is just to show you, and they put here the Diglodeg. You can see the Diglodeg goes more than 24 hours, although it's approved only for 24 hours. And we hope, when it comes, maybe we can use it every 2 days for patients, but that's going to be off-label for most of our patients. Okay. Basal insulin oral combination therapy is also very good. You know, when you start insulin, doesn't mean you stop your patient's oral hypoglycemic agents. I don't stop metformin at all because it's the safest drug. Metformin will keep the patient weight less, so the effect of insulin less, and also metformin will do something else. شنو هو؟ No, something, we know it in cardiovascular, but most important, reduce the risk of cancer that associated with insulin over a long time. So metformin is the best drug to use all the time, and never stop it. And it doesn't cause renal failure, as many primary physicians say, and I always say it when I give a lecture. Many primary care physicians, they put a fear in their patient. للأسف. Some people do that. Maybe someone here, I don't know, but there are some doctors who tell the patient, metformin حيذبحك, كلتك, مش عارف ايش. It's all totally wrong. Now metformin even is allowed in renal failure. Metformin doesn't cause renal failure. We don't give it if you cannot secrete it. That's the way we tell our patient. Okay, so it's a good drug, and never stop it when you use insulin. Also, you can use combination therapy with sulfonylurea, and I do sometimes use it. But we have to be aware about hypoglycemia. Avoid older generation sulfonylureas because the rate of hypoglycemia is high with it. And I really discourage you from using old generations. So من الدياب ودواني اللي متوفرين بالهذا. I also personally worked hard to stop them in the ministry, but we couldn't. But خلاص, there's no reason to use them. So for when I use, you use اللي هو Damacron MR or Amaril, which is available, the new generation. So this is from the ADA. I don't know if you can see it, but basically what they say, you either start at 10 unit or you go with by weight. And basically, I don't use the weight issue. The weight issue, we use it for type 1, newly diagnosed. We calculate the weight and then we give the patient. These patients usually an oral hypoglycemic agent. We just add usually a 10 unit, okay? And then they give you can download it, or I can give you the slides if you want. And then you add a basal insulin, and that's what we do when you first move from oral to an insulin, and then try to adjust it, and then you can add pre-meal or go to premix based on your patient. I'm going to show you more slides. This is patients with type 2 diabetes, intensive insulin therapy, basal bolus compared to continuous subcutaneous. A pump compared to basal bolus. And you can see the same, تقريبا the same effect. So nothing that you can do with a pump, you cannot do with an injection. Okay? So the injection works, but you have to do it in the right way with the right dosing. Okay? This is where I tell my patients, so basal insulin titration, usually basal insulin, أنا أقول له start 10 units, tamam? Increase the dose by 2 units every 4 nights. Don't be very aggressive on the patient. Then the patient will not test every day, and if he tests every day, we don't want him to change every day. You need at least 2 half-lives to the drug to become, stable in the body. So actually 4 days is okay, and then أقول له, if your blood sugar between 5 and 7, you're fine. If they are above 60, probably I'll tell them between 6 and 7.5 to 8, because we don't want to have hypoglycemia in older people. والمريض نفسه يعد الجرعة. So أنا أكتب مثلا I start with 10, أعطيه مثلا 30 or 40, واكتب للصيدلي إنه he will start with 10, so give him more. And then he will adjust by himself, and then with time he will know that he will correct. By the time he comes to you again, he's probably taking 20 or 30 units and his sugar is much better. So why do we use premix insulin? Now we know everybody is saying basal bolus, but although I lecture about basal bolus a lot, but I still do use premix insulin. Okay? Post-meal blood glucose is earlier detectable glycemic abnormality, as we said, because of the loss of this first and second insulin response. So basal bolus helps with that, عفوا premixed. Post-meal blood glucose correlates with HbA1c, and that's very well known. So using premix does lower your A1c. Targeting post-meal blood glucose may improve overall glycemic control, and elevated postprandial glucose associated with development of vascular complication. And this is well proven that your postprandial glucose, because it's increased the flux of free fatty acids, and that will make your vasculature more prone to ischemic heart disease. Okay, so postprandial hyperglycemia is basically related to all of these things: cancer, cardiovascular disease, many other risk factors related to mainly macrovascular disease. So we know that postprandial glucose is important, and that's why you have to think. For many years, we were pushed with basal insulin, and we forget about the postprandial. So don't forget about the postprandial, and that's the message. And we know that your HbA1c, between fasting and glucose, the lower your HbA1c, the more contribution to your postprandial. فإذا يعني واحد يعني عنده مثلا HbA1c of 7.8 or 9, and he's on, or 8, and he's on many drugs, and I want to add insulin, sometimes I just give them خليه يفحص في البيت, and then I see where's the problem. If his fasting glucose is okay, there is no reason to give him basal insulin. So what I would give him short-acting insulin or a premix once a day from the main meal that you have a problem with, مثل الغداء مثلا. Or patient يقول لك خلاص يبقى بعد الغداء دائما shoots up, but in the morning he's fine. So, and we know from this that if his HbA1c on the lower side, probably it's more postprandial than preprandial glucose. This is to show you that this is 12 hours per day spent in postprandial state. So you can see most of the day goes with the postprandial. Giving basal insulin, although it is one of the recommended first line of insulin introduction to type 2 patients, but we have to think about postprandial in our patients, especially who eat a lot. فالبيزل انسولين will not cover them. فتشوفه تعطيه لانتس ويجيلك بعد 3 أشهر A1C للحين 9. What happening? You corrected the fasting, but you did not correct the postprandial. فthink of the postprandial. فأنا شخصيا, I tell my patients when they first come as referral, I give them this فحص قبل الريوق, بعد الريوق, بعد الغداء, بعد العشاء. 4 points. And do it every day once, or come for me after 2 weeks. So he will have 2 readings in every point in the day. Simple. مثل شو يقول إذا أردت أن تطاع اطلب المستطاع. You don't tell him to test 5 times a day and then when he comes to the clinic, 5 times a day, and when he comes, basically, you don't look at it, some doctors. That will tell your patient that you're not interested. For postprandial is important. So we have mixed 25, and it's not available in Ministry of Health, but it's available in the market. We have mixed 3070, which is the one we are used to, either Mixtard or Novomix. Ana shakhsiyan, I don't use Mixtard at all, unless the patient is non-Kuwaiti. We'll give it to him. And Humalog Mix 50, and you heard about it today, the new Humalog Mix 50. Ana shakhsiyan, I use it because it's available in my clinic in Ahmadi Hospital. And this also have more twist toward postprandial compared to the 3070. Okay, so most patients use Mix 25 or Novomix, as Ian Craston said. Most of the combination we use is 3070 because of the availability and widely used for many, many years. The 50 is actually just came to the market a few years ago. So pros and cons of premixed insulin. The pros, it covers overnight hyperglycemia and address postprandial excursion. So you take 1 injection at night, you cover the dinner, and also 12 to 18 to 16 hours in the night. Inject at the meal, likelihood of preprandial hypoglycemia is there, and the mix improve cover lunch and late night snacks. So it have some, coverage to our patients' meals. And the cons, must be given at mealtime, not like the basal insulin. You can take it anytime, like Lantus. You can take it أي وقت باليوم. Doesn't matter, morning or night. Studies show that all the same. Okay. The problem is in the old human insulin, you have to wait for 20 to 30 minutes. For the new analogs, you don't have to wait, so inject. This is also solved. Okay. Sometimes it doesn't cover the whole day, and sometimes it causes postprandial hypoglycemia. إذا البيشنت قرر إنه ما يأكل, and it's difficult to adjust. So that's why when patients who really want to adjust their meals and do carbohydrate counting, basal bolus is much better than premixed insulin. But for patients who have fixed doses, fixed meals, probably premixed insulin is better. This is Novomix versus Mixtard, and you can see the difference. The acute effect of the short-acting insulin in the Novomix much better than اللي هو الأكترابid, and you can see with time it goes down. It doesn't cause you hypoglycemia. So the new analog is much better than the Mixtard. This is again show you. This is Novomix versus Mixtard, and you can see this is the mean prandial glucose, and you can see it's much less because the patient, more compliance, less hypoglycemia. You take it with the meal, and it works better. Again, this is with hypoglycemia, and you can see the events is much less than the Mixtard. That's why I discourage you from using Humalog if you can use it. But if the patient is actually non-Kuwaiti, for now, probably you don't have to push him to buy and overwhelm his budget, because Mixtard still works, but you have to adjust the timing to avoid hypoglycemia. Okay, this is Lispro Mix 50 3 times a day versus MPH, and you can see that it's much better in terms of the mean HbA1c reduction, and it all because not only MPH covers the insulin, the glucose, but because most of these patients will have more effective glucose lowering and less hypoglycemia and more compliance. This is to show you the mixed TID with basal bolus, and it shows the same effect. So I use the mixed insulin, so 30 or 50, I do use it 3 times. I give it at the lunchtime. I give a smaller dose in the morning, bigger dose at lunchtime, and a little bit smaller dose in the evening. So you'll cover the 3-1, and you have the whole day covered with the long-acting. This is, again, one of the titration suggestions, and there is lots of things related to calculations, but basically, if you want to go with the 10 unit, which is we used all over. حتى they put that you can use the total daily dose over 50 and all these things, but at the end they can say you can start with 10 and adjust with time. And this is basically more with type 2. With type 1 is entirely different ball game. We're not talking about it today. Okay? Are you using insulin as a threat to the patient? Are you? Yes, أنا بشوف في ناس كتير كده, but probably some of you, or maybe us sometimes, we threat the patient. إذا ما ضبط وياك ترى بعطيك إبرة. This association between insulin as a threat later in life, this was stuck here. And we know it's